A warm welcome to another edition of Wellness with Will. My name is William, last name Lahong. Our guest today is Dr. Lerato Rabanye, who is a GP with an interest in mental health. Doctor, a warm welcome to Wellness with Will. When we talk about your daily call it duties, right? What does that look like from someone like yourself who is a mental health activist and sees mental health patients?
All right, so thank you so much for inviting me onto your show. It is truly a privilege to have some time to share with your viewers. So as you indicated, I'm a mental health care practitioner. I'm a general practitioner who has had the fortunate experience of having training in psychiatry.
Right.
And I work in a psychiatry department within a public health facility. So what we basically do on a daily basis is that we encounter patients who come through to our unit with mental health care problems.
Okay.
So people would be at home presenting with behavioral problems. And when we say behavioral problems, obviously we're not talking about things that are minor. We're talking about things that really impact on people with regards to their occupation, with regards to their interpersonal relationships, and as well as their daily, basically their daily lives.
Right.
And when you start having behavioral problems that impact on people in that particular manner, it overspills to those who are around the person who's basically experiencing the symptoms.
Sure.
And very often they would then end up having to come and consult at a hospital for intervention.
I get you. And that's the very intervention that we are having this conversation about.
Yes.
Because within our communities, as Africans in particular, there seems to be a misunderstanding or misinformation, if you will, about what mental health is,
Yes.
which then leads to people being misdiagnosed, right?
Yes.
Sometimes you'll find people being sent to a spiritual healer because they are saying, "Unaleme moya," meaning this one needs to go for initiation. But
Yes.
when they walk through your doors and they are in your care, they are guaranteed the best attention and appropriate treatment, as it were.
Mm-hmm.
And how does the diagnosis process work, doctor? I mean,
Okay,
what
right.
happens first?
I'm glad you actually came with that particular question. So what is very important for people to understand is that before anybody is diagnosed with a psychiatric condition, so meaning that diagnosed with a mental health condition,
Sure.
we need to ensure that we rule out any underlying medical problems.
Right.
So there are different conditions, which may be medical conditions, that may lead to people actually presenting with abnormal behavior. And it can be as simple as a deranged glucose level. So for instance, somebody coming in with low glucose may literally start presenting with symptoms that present like a mental condition.
Because their glucose is low.
Is low. So they may have a disturbed mental state, they may start hallucinating, they may start being aggressive, and those kind of symptoms. So what is critical is that every time we have a patient who comes into any facility having abnormal behavior, it's important that we actually exclude underlying medical conditions.
Okay.
So just to give you an example, it's not to say these are the only conditions that can change one's mental state.
Sure.
I mentioned the issues about, e.g., glucose levels. I'm just going to your basic simple.
Right.
So we run a few tests, and in these tests, like we're testing for infections.
Okay.
So there are certain infections that can cause a patient to actually have a change in mental state.
Okay.
So somebody can literally have a urinary tract infection, and it
Okay.
can manifest in them actually developing symptoms that are in keeping with somebody who's not well mentally.
Right.
So in that state, we say that the person is actually delirious when they are in that state.
Okay.
And delirium is a condition that is seen to be an emergency in medicine.
Okay.
Why? Because if the underlying medical condition is not treated, then the chances of a patient complicating and even having a fatal outcome are possible. It is therefore important that when you see somebody who's presenting with abnormal behavior, you don't make an assumption that that person is mentally ill or having a psychiatric condition.
Okay.
So I just spoke briefly about glucose levels. I spoke about possibility of infections.
Right.
Something as simple as having a lesion in the brain.
Okay.
There are people who can come in presenting with abnormal behavior. And if it's a first presentation, it's also very important that we also do things like brain scans,
right,
so that we check out for any lesions in the brain. Conditions such as your meningitis.
Okay.
It's an infection, obviously. It can lead to somebody manifesting in abnormal behavior.
Okay.
But then there can be tumors, and depending on where the tumor is placed within the brain,
right,
it can manifest in certain conditions. So just to highlight one example of something that comes to mind, there is a patient who had come through to our facility having been to other places for quite a long time, and the symptoms that were being treated on this patient, everybody was looking at treating this patient for a depression. Everyone was going depression, while the patient had a low mood, was apathetic, loss of interest, withdrawn and all of that.
Right.
But it turned out, when finally they managed to get the booking for a CT scan to be done, it turned out that this person actually had a tumor, on a particular area of the brain. So it is very important that tests are run. So we test everything, literally. It almost sounds like it's a waste, but it is worth the exercise, because if you do not manage to spot the underlying medical conditions,
right,
you are going to miss the boat, and you're going to end up with an even further complication.
It could be severe even, because you haven't addressed the medical
conditions. So it does happen that once you address the medical conditions, then the mental condition just becomes resolved, because basically it was just a temporary state that was induced by the change basically in the patient's medical condition.
Sure.
So, there's a whole group of conditions, even epilepsy. Epilepsy as an illness can manifest with what we call neuropsychiatric symptoms.
Okay.
So the patient who's having epilepsy can end up displaying certain symptoms that may be in keeping with somebody who's having a mental illness. But actually you find that when you can control the epilepsy, then the mental condition also becomes controlled.
Right.
So I feel that we need to start educating people more about how mental illnesses present,
right,
so that they don't make a quick assumption that when they see abnormal behavior, then it is purely psychiatric, which is why it is important to look at finding a doctor who can be appropriate, if
sure,
you can call it that,
sure,
in running proper investigations. We all know that taking certain substances can also induce certain mental conditions.
Yes.
And we live in a very unfortunate era where there is so much access to substances, drugs, alcohol, and all of that.
Right.
And these are mind-altering, substances, and they manifest in certain symptoms that the patients would be coming with.
Sure.
So somebody, there's a very casual talk about, people will say weed, we just puff and pass this
yes,
and that. But the fact of the matter is those are mind-altering substances. They
right,
may induce certain symptoms. People may start hallucinating. They may start developing things like your delusions, having fixed false beliefs of things that do not exist.
right,
But in their mind, it feels
it's real. Yeah.
Yes. So we need to run tests to exclude all of these underlying medical conditions.
Okay.
Once we are certain that all of the medical conditions have been excluded, then we can safely say, now we are going to treat you for a psychiatric condition.
I
And
love
that is
that.
now when we start treating. So it is in that process that we feel communities need to be educated, that talking to self, laughing to self, acting odd, and all of that is not necessarily always psychiatry. It might at times be things that needed to be investigated, to be treated properly so that the person can be returned to normality.
I like that, doctor. And obviously, if you then open up that door, you have now gone through the checks and you are establishing that this patient indeed or definitely needs mental health attention.
Yes.
There's some psychiatry that needs to, like a psychiatric intervention that needs to take course.
Yes.
Would this be after one session having visited you, or are these tests for infections and all the physical manifestations done over a period? Or is it something that happens just over one day, then I come back tomorrow to start the mental health sessions, as it were?
All right. So we treat each case as necessary. So let me just explain to you how it is. So what we do from where we are, we have what we call a biopsychosocial approach to treating conditions.
Okay.
So there's biological intervention,
Right.
there's psychological intervention, social intervention, and we also have a cultural approach that we also need to acknowledge in the system.
Right.
Because at times people have got a cultural view about the conditions that they have, and you've got to respect that.
Right.
It doesn't mean that just because I don't have a proper understanding of what is happening culturally,
Right.
I need to be completely dismissive of what it is that people are experiencing.
So you do factor in the cultural aspect.
Yeah, but what I'm saying is it's not our area of expertise, but
Right.
we need to have an understanding
Sure.
of what people's cultural beliefs are regarding a particular condition.
I get
it's
you.
It's not to say that that's how we intervene, but I'm
Right.
saying it's basically a holistic view of looking at a patient who's having a mental illness.
Right.
So I'm just going to give you like certain examples of, how we go about it, just a clear example of what happens.
Okay.
So a patient comes in,
Right.
and this patient is now presenting with abnormal behavior.
Right.
And when we say now we have a biological approach to it,
Sure.
we are now going to run the investigations. And it's a myriad of investigations. It's not just the few investigations that I spoke to you about.
Sure.
It's a number of tests.
Right.
Then after we are convinced that this person is now clear, there's no underlying conditions for us to worry about,
Medically speaking.
medically speaking.
Right.
Then now we are saying now this person, we believe now this person now has a psychiatric condition that we need to address.
Okay.
Then what we do, we have certain types of admissions that govern how we admit our mental health care users.
Okay.
And it is basically something that is governed through the Mental Health Care Act. It is by law that we must admit patients in a particular manner. So I'll just relate it out to you.
Sure.
So we've got certain types of admissions. We've got voluntary admissions.
Okay.
And a voluntary admission is somebody who understands and knows that they've got a medical condition and they need help, and they bring themselves, for the help that they need.
Right. This is me giving consent in my right frame of mind, understanding what it is I'm signing up for.
Thank you.
Because I realize the need for it.
Thank you. And then we've got other types of admissions under this particular. We've got assisted mental health care users.
Okay.
Right? And we've got involuntary mental health care users.
Right.
Then we've got what we call mentally ill prisoners, and we've
Okay.
got state patients. So I'm
Okay.
just going to run through just a number of them so that you understand how it
Sure.
goes. So when we say somebody comes through to the hospital and we are going to admit them as an assisted mental health care user, this person does not have capacity to consent. So
Okay.
they are mentally disturbed. They do not have capacity to consent.
Right.
However, they are not refusing intervention.
Okay.
Right? So when we admit this particular patient, there are certain processes that we have to follow, and this is recommended by law.
Okay.
Of how we are going to admit this person.
Procedurally speaking. Right.
And then we've got what we call the involuntary mental health care user.
Okay.
So involuntary mental health care user is that patient who's running havoc in the community.
Okay.
They can essentially be of risk to themselves, to others, by others, to property. They're breaking windows at home, they're damaging property.
They're prone to self-harm.
They are prone to self-harm. So in that regard, we say you do not have capacity to consent, but at the same time, you are not open to the idea of receiving help and intervention. You do not want rehabilitation.
Sure.
You do not want help.
Yeah.
Then we admit you as an involuntary mental health care user. And even that process in itself has got certain procedures that need to be followed.
Sure.
So it's basically like when you're a healthcare provider, you understand all of the forms that are necessary that need to be done in order for this person to be admitted in this particular way.
Okay.
So now, what is the difference now between the assisted and the involuntary? The difference is this one, the involuntary, is probably your very aggressive patient.
Right.
Who is highly dangerous to self and to others.
Sure.
And also who may be prone to damaging property and all of that.
Right.
And they do not agree that they've got a mental condition that needs, some kind of intervention.
Sure.
So this is sometimes what families go through. They struggle, they sit with somebody that they can all see this person is not okay, but they do not understand what they can do to forcefully get help for this particular person.
Right.
So you can even go through the law in order for you to actually get this person admitted. You can go via the police to ask for assistance for this person to be brought into the hospital.
Okay.
So obviously, patients are all treated with dignity. Even when you are an involuntary mental healthcare user, you're supposed to be treated with dignity.
Sure.
But the truth of the matter is, we have a responsibility to keep you safe from yourself, to keep others safe from you,
around you.
And you understand. So it's about risk mitigation. But then obviously, then we put you through into the center where you will be observed over a period of time, and a decision will be made as to how to further admit you. So you come in now for a 72-hour observation.
All right.
Where on a daily basis, for every 24 hours that you are at the center, you need to have your mental state examined. And by the time of the 72-hour being done, if you are still found to be problematic, you are likely to continue as an involuntary mental health care user.
Okay.
Or you will then be changed to be an assisted mental health care user, depending on what it is that the
severity of
is.
it.
Yeah. And then, of course, now I'm going to go to the other two. But those ones now do not apply in your general hospitals. So the assisted, the involuntary, as well as the voluntary can work in general hospitals.
Okay.
But then the minute you start going to your mentally ill prisoner, these are the kind of people who would be unwell mentally, but in correctional facilities.
Okay.
Right? And there are a lot of people who are receiving psychiatric intervention in correctional services.
Okay.
Right?
Because those conditions are or present themselves very severely in those patients.
But remember also with the prisoners, you'll find that there's a lot of substances that they were either exposed to prior or during the time of the admission or whatever. But and it's a very stressful environment, obviously. So that stress in itself can trigger mental conditions.
Right.
And if they start developing symptoms when they are actually in prison, then they would be regarded as mentally ill prisoners, but they would be receiving treatment nonetheless. All right. And then you've got your state patients. Now, who are state patients? These are the people who have been found by the courts to be, guilty perhaps of certain crimes.
Okay.
But what has been determined is that the underlying mental conditions that they had were the reasons behind the committing of the crimes that they have. So they have been deemed to be, they are not accountable, or they do not have capacity to understand the severity of whatever crime that they've committed. But then these are the people who end up in your forensic psychiatry units.
Sure.
So they would end up in the big hospitals which has forensic units. You've got your Viscopis in the Tshwane areas, you've got your Sterfontein, in the Gauteng, Joburg area, if I can call it that.
Right.
So there are different, and I think Bophelong has a forensic unit. I stand to be corrected with regards to that in the Northwest Province. So each province kind of like has a unit that has its own forensic sort of like facility.
Sure.
So not everybody gets, lumped up or clumped up into one facility. It just depends on what the circumstances are, and then the patients are put in the appropriate place accordingly.
Thank you so much for unpacking that, Doctor, because a lot of the times when we consume creative content and we see the context of someone who has committed a crime, be it murder or something even more severe, like blown up a community, when they go to court, they plead, they call it momentary insanity, I think is the term that's thrown around in the creative realm. This is in film and series, right?
Yeah.
But in reality, when you are now faced with these, as you were saying, state patients, the 72 hours doesn't then apply, right? It's a lot longer, and it could be a more prolonged session.
All right. So let me just clarify something to you. And I'm saying this not as an expert, obviously, but as somebody who has some knowledge of how the process gets followed.
Sure.
So essentially, when you look at people who ultimately become your state patients, right? They would have been, one, the person is supposed to have committed some crime,
right? And
that crime would then be related or supposedly related to the mental illness that the person has.
Right.
So what happens is, through the Criminals Procedures Act, right, the courts would then make a determination to have this person admitted into a forensic facility, where they would then make a recommendation for this person to be observed for 30 days.
Okay, so that's an entire month.
That is an entire month of observation by the different experts. And you would have on board your psychiatrist, who happens to be, the leading team member. You would have a psychologist, you would have a social worker, you would have an occupational therapist.
Sure.
So the whole team, including psychiatric nursing. So the whole team is responsible for putting the patient under observation for that 30-day period. And after that 30-day period, they then compile a report, which would be a compilation of, it would be inputs basically from all of the team members.
Sure.
And then from that particular report, they make a determination of whether that person is accountable or not accountable for whatever crime that has been committed, or they've got capacity or they do not have capacity to understand.
Based on their evaluation.
Yes, based on the evaluation. So that in itself is a special process which does not include your general hospitals.
I get you.
So for instance, I work in a general hospital.
Right.
But then this type of process is basically in the area of forensic psychiatrist.
Yes, right? Which is a different department.
Which is a different department. So I think the purpose was just for me to clarify to you that we actually have different types of admissions within psychiatry. It's not one patient and it's a blanket rule for everybody, this is what works.
Yeah.
You've got to look at the case and understand what it is exactly that you're dealing with, and then send it to an appropriate place, whichever way.
Awesome stuff. Doctor, thank you so much for your time and just joining us on the Wellness with Will edition today. We're obviously going to need a part 2 of our conversation to unpack what the relevant treatments would be for those patients that you've just mentioned, the 5 different ones that you deal with in the different and various hospitals. A big thank you to Dr. Lerato Rabanye, who is a general practitioner but also very passionate mental health advocate. Thanks for watching. We'll catch you on the next one.